Welcome to the Deep Six podcast, where we make a generational impact on you and yours. What we do here is explore a 6-point model into your health, your life, and your journey while you're here. So let's dive deep and help you thrive, not just survive. Hello again. Welcome to the Deep Six podcast. This is Dr. Lewerenz, coming from Longevity Health Institute. And if you're new to us, we explore a 6-point model in our practice, which I brought to this podcast, the Deep Six. So, we unravel and talk about life things, the journey of life things, but things that are very impactful in medicine, but also in life. And of the six, it's a 6-point model, are genetics, hormones, your gut health, including diet and nutrients, toxins and how you detoxify, mind-body, which we know is so important, the mind-body connection, and then structural or pain issues. So, in the Deep Six, we talk about a lot of things, have a lot of different guests. And today I have I appreciate it deeply, a wonderful guest, a ER doctor from Michigan here, from Michigan State University. He's got a background in emergency medicine. He's a DO. He actually is now the clinical coordinator for, I think, a number of years at Michigan State's osteopathic school for their PA program. Has actually recently connected me with a PA to, mentor and do some training they're going to do under me. And welcome, Dr. Dan Richardson. Thank you.
Yeah, nice to be here. First experience for me doing this, so hope it goes well.
Oh, you don't have to. This is easy. This is easy. You just talk.
I'm good at talking.
Right. Yeah, exactly. Well, in ER medicine, right? You had to, right? Didn't you? I mean, you had to be kind of a people person, right?
Right. Well, in the emergency medicine, you get 2 minutes to meet someone and convince them to trust you. So that's a big part of it, being able to communicate.
Yeah, absolutely. So, I always, again, you are how many years in the emergency medicine?
I finished training in 1992, so 32. It's bad math, quick math.
Wow.
32 years.
Okay. Wow.
Mm-hmm.
And you got out of it, and you're now a clinical coordinator for the PA program at Michigan State.
Correct.
And obviously that's very different than ER.
Yeah. It is. It is.
Yeah. Was there a reason or a purpose for that, or just a shift?
Well, I did my training through Michigan State in Lansing. I did my training here, and then time came to get a job. I took a job in, the Detroit area. I grew up in Oakland County, so I took a job back down there, and it's not where I really wanted to be, but I thought I'll just grab this job now. It's a job. I had a buddy who was working there I knew, and I thought, well, this would be a good first job. And then 25 some years later, I was still there and driving an hour to and from shifts that ended sometimes at 3 a.m. in the winter. And
wow.
It got difficult, the drive, being in the same place, the same thing. So, it was time for me to make a change a little bit. So I stepped away at that period of time because I have twin kids that are now grown and gone, but they were in high school. They each played 3 sports. I was working hard to get to those and missing things. And they're the only 2 kids I have. So I wanted to be around, and I knew they were going to graduate and leave. And if I worked through high school and then quit, that was crazy. So I thought I'll just step away now. And if I want to come back when they're gone, I'll come back. And I did that a little bit, but I was able to be around them and their high school experiences and their sports, and took a lot of pictures on the sideline and was kind of the sideline medical, if needed, kind of guy. And I enjoyed that a lot. But then they left me and they went to college.
And then they ditched you.
Then they ditched me. And my wife is still working full time. So I started working a little bit at a critical access hospital in emergency department, a 16-bed hospital. So my whole career was spent at a, big hospital with residents and trauma and lots of other docs around to talk to and interact with, and to a little place where I was the only doc there. So it was a big difference. It's a hard job to work out there by yourself, where you don't have your buddy there to look at something or bounce things off of. So
absolutely.
And I did that for a while, and then came a time I was just ready to be done with that too. So Then I came across this job as a clinical coordinator, which keeps me in social circles, which is mostly what I needed for my
Yeah.
mental health.
Yeah. Yeah. We all do, right? I mean, we all do.
Yeah,
We all need that connection and stuff. I mean,
right.
my practice, we have a few locations and, 20, I think I have 27 employees and 7 practitioners. And long
Wow.
story short is I love that. I love the culture of going in there, talking to people, sharing cases, hearing about their life,
Hmm.
and actually, you learn from them too. I don't care how smart you are, how much you're well read or, age, a lot of them are younger than me, obviously. And
Hmm.
it's kind of like I learn from them and they think they're learning from me.
Right, right.
So
The day you
it's
stop learning is the day you should not be doing it, right?
for sure. Absolutely. Absolutely.
Yeah.
Yeah. I have a saying, I probably said this before on the podcast, but I always say this, even when patients question me about some stuff and I say, I'm always
Mhm.
married to my questions, not my answers. I can put my
Yeah,
ego aside because it's like, hey, medicine especially evolves all the time.
right.
So, yeah. So, well, anyway, thank you again for joining us. And I do want to get into a little bit about ER because I did
Hmm.
an ER residency. It's how we know a mutual
Right.
friend, and
Ricky.
yeah, Dr. Rick Trikoff, and you guys worked together for a lot of years, I believe.
Hmm.
And
Yes.
my medical director, my residency director, excuse me, in emergency
Okay.
medicine back at Garden City Hospital, the DO hospital. In the beginning of my residency, my family practice ER residency, and anyway, long story short is that's how we're connected. He always talks very, very, very highly of you, by the way. And I know you don't see
Hmm.
him much anymore, of course, but
No, I don't.
yeah, but I mean, the ER stories that I had, it's just such a people don't really fully appreciate it unless you're in there, you
Right.
know, good and bad.
Right. First,
It-
first, Rick's a great guy, and when you pulled into work and you got there and Rick's there, you knew it was going to be a good shift.
yeah, that's
So,
good. Yeah,
because he's a great doc and he's a laid back, easygoing, which is everything, in that department to have that attitude. So it just made the job easier.
yeah, yeah. Well, he was my trainer. So the one thing with him, and I had others like this, which when you're a student, any type of student in anything, even if you're confident, stuff or whatever, and you're learning, you want that person to obviously have your back and to like get some info on, but
Hmm.
also to give you the reins a little bit. And he was kind of like,
Right.
like, hey, you got this, but let me guide you a bit in
Hmm.
that. So
Hmm.
it was great. I also, especially when you're your first year, you don't realize necessarily what you're getting into a little bit when you're an intern and you're in the hospital, but I just will never forget some of the stories that were, just at a different level that
Hmm.
you picture the heart attack, you picture the stroke, you picture the trauma, I guess, if you will. You don't picture some of the psychological stuff, some of the
Yeah.
family
Right.
impact stuff, some of the alcohol and drug stuff. And that was a big, eye opener for me.
Correct.
I'm sure you don't
Yeah.
miss that.
Well, I kind of do miss that
Oh,
because that's the personality type that's drawn to emergency medicine, right? You want to be in the mix, in the drama, in the confusion a little bit. Um, I miss the medicine part of medicine. I don't miss the administrative part, the volume part, the no beds part, the being not having a place to send someone or not having the resources to help someone. Like you said, the drugs and alcohol, you see these people that come in with problems. You see them over and over and over, you know them by name,
yeah,
like, hey, Kenny, where'd you get those shoes? I stole them from Kohl's. Kenny is
right.
one of our regular guys. But, and you want to help them, but what do I have available to help that person? So it gets frustrating. You send them back out on the street and they come back and they see you in the next day or so, or
Yeah, yep.
those are the things that cause you to burn out. I think I never burned out from the medicine. I enjoyed the medicine part. And like you said, always learning new things, always doing things that are new procedures or learning new skills. But there's so much beyond your scope of what you can do that
Right.
affects your patients. So
Right.
it's
Yeah.
hard.
And I found, and this is going way back, man. This is going back, geez, 25. years-ish, 27,
Yeah.
8 years for me.
Yeah. We all do.
I found that, which you don't realize, you go in passionately and you don't realize it's a business and it's a hospital administrative operational thing. So there's all these layers, and you go in and you're trying to always, of course, do the right thing. But like you said, sometimes your hands are tied. And then
Right.
at the same time though, too, it's a little bit of a dumping ground. People don't,
Sure.
like at least I don't know if this is like this now, but it used to be literally where people, docs would send didn't know what to do at the office to the ER,
Sure.
and
Right.
it might not necessarily be an ER situation, and now it's your problem, and
Sure.
could be a social situation,
Correct.
and you might just have to get social worker involved or something. But it's like, again, that's those things that you're like, what do I
If
do
you
with
have that
this?
available. Right.
Right. Well,
Right.
exactly.
Well, you become a dumping ground's a bad word, but it's not
Sorry.
wrong.
Yeah. But,
No, it's not wrong. It's not wrong. Often we get people, the police will come in with someone and they just walk in with someone walking in and you're like, what's going on? Oh, he was drunk at 7-Eleven. I'm like, okay.
right. What do we don't have a magic wand to get him undrunk.
I don't have a treatment for that. They're just in the wrong place doing the wrong thing. I'm like, is he under arrest? No. Does he want to be seen? No. I'm like, why did you bring him here? So
Right.
it's kind of tag, you're it. He's yours now. And,
Yeah.
if you don't like police and firemen and, those kind of people, you shouldn't be in the ER. So
Yeah.
the fire and police guys were our friends.
Oh yeah.
But at the same time, they would create issues for you. But,
Yeah. Yeah.
they also
Yeah.
had our back. If we had problem in the department, they'd take care of it. So, but
Right. Yeah. Yeah.
like you said,
And they do. They
you
do.
often-
I remember some events myself where things you wouldn't expect. I remember a doctor was wheeling an older lady. Actually, it was one of my my trainers, and he was. I mean, by the way, a nurse could have done this or whatever, but he was just trying to help out, and she was frustrated probably at waiting time or at something, and when he went to wheel her down the hallway, and she took her phone, and this is an older lady. I'm sure it was out of frustration. She took her phone and she smashed her phone about like swung at him, hit him in the face, and he ended up being a patient. He had to get stitches
Right.
on his shift.
We had that exact same thing happen with one of our docs. Mark, one of the docs, got hit by a patient hitting with her phone. So,
Oh yeah. So
I'm lucky in that I got through my career without getting hit, but you kind of learned that how far you have to stay away.
Right. Yeah. What's good?
I was taught early, never let the aggressive patient get off the cart because you'll lose. Once they're up, you're in trouble. Keep them
You're
on
in
the
trouble.
cart. Keep them on
Right.
the cart. Yeah.
Exactly. Yeah. Absolutely. Yeah.
So I do miss that drama, that chaos, that stuff. Now I have, my daughter is a fresh grad nursing. She's an RN. She's
Okay.
working in a local hospital in the ER, and she comes home every day with stories of, this happened, that happened. I'm like,
Yeah.
So,
But-
it's
yeah.
just like, it's
Yeah.
kind of fun to hear those stories again. But
Yeah. No, for sure. Because you've lived it. You obviously helped.
Yeah.
Obviously, you
Yeah.
were part of the solution. Usually, I'm sure.
right.
I actually. So my journey was, and a lot of people are surprised by this because they're like, "How did you end up?" First of all, doing this like longevity preventative stuff, but how did you end up there to
Right.
go in family practice? Because my innateness was to be an ER doctor. It was just, it's funny. It's something that you kind of said, and this is where in medicine, the interweaving of family and, your relationships and your kids, I remember being sickened as a resident when I'd work late at night, like nauseous, missing my family. I'm missing some, like my daughter was going to, sounds funny now because
Yeah.
she's 27, but she'd have like a ballerina thing or something,
Correct.
and,
Yeah,
and I was
100%.
just like, man, I don't know if I can keep doing this my whole career. Yet I love to like float a pacer, or I love to like,
Correct.
say, do some, a central line or whatever. I was a procedural person. I loved intubating, all that
Correct.
stuff. And I miss that stuff. In fact, actually, I do some procedural stuff in the office and people are sometimes shocked by it and I simply basically do it because I love that stuff of medicine,
Part of
and yeah. So, but I don't love those hours sometimes.
The
I'm sure.
hours are getting bad, like you said, with kids. My wife's a physician also. She's a general surgeon. So if you talk to my son and my daughter, they're twins. If you talk to them today, they're 23. They will tell you they don't remember either her or I missing any of their school activities.
Wow.
So,
That's
and it
impressive.
was hard. It was hard to do that,
Yeah. Yeah.
maybe easier for me than her, but we just made it happen. It was a priority. We were at band concerts. We were at the ballet thing. We were at lacrosse and football and volleyball and
Right.
basketball and, all those things. And they don't, to them, we were just there
Yeah.
always.
Yeah. Yeah.
Now that they know what we did, my daughter especially, I work a day shift, then I'd trade a shift and work a till 3 a.m. shift just to try to be at their activities. So
Yeah.
it's physically hard on your body. You have no sleep cycle for 25 years, but
Right.
it's worth it now looking back that we were there.
Yeah. 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 That's, oh God. Yeah. It's, I don't regret it at all because just, I got to a more, for me, more, it's not quite 9 to 5, but you get to more of a 9 to 5 job, very predictable, not
Right.
weekends, not nights.
Well, a little
like
bit. You're the boss too, right? You can
well,
sneak
yeah,
out,
I mean,
maybe.
yeah, well, yeah, for sure. I mean, autonomy, you kind of, I was fortunate enough to work with my dad. My dad was a physician.
Right.
I was with
I
him
know.
for
Yeah.
3 years. And then, just kind of different philosophies and medicine and life and stuff like that. So I went on my own and then, got into this more wellness space and stuff like that, like about 17 years ago. So, autonomy. I don't know. I tell my kids this, man, if you get the opportunity, as much autonomy as you can achieve in what you love and what you're passionate about, that's what you want to go for, because I believe that's a lot of true happiness.
Correct. 100%.
So,
Yep.
yeah. So I have a quote. I always love doing a little quote on my podcast here, and I want to get your take on it. And I'm a big reader. I love to read a lot of different stuff, but this quote is from Lewerenz, and it's, "No man was ever wise by chance." So I think this is really appropriate too, because you're, a clinical coordinator for all these kind of students, right? They're students.
Yeah, they're students. Yeah.
They're students. Yeah. To a degree. I mean, they're elevated, high achiever students.
They're paying tuition, put it that way. So
No, that's true. Yeah. Correct.
they're
Yeah.
students. Yeah.
Yeah. Yeah. But they're our future of medicine. I mean, they are our future.
100%.
So, this quote, what does it, essentially mean to you? And, you don't become wise by chance, do you?
Well, I think, wisdom and intelligence, different thing, isn't it?
Yeah.
You might be intelligent, but that doesn't mean you have wisdom. I think wisdom is something we gain or we achieve, whether by experience or by effort. By living your life, you become wise just by having experiences, whether that's going to school and being taught or reading or doing that, or whether it's by just, being in the ER and, seeing patients. And, it gets to a point in your career where you can sit at the desk and say the kid down the hall in 27's got croup, who's seeing the croup kid down there. And you haven't seen the kid, but you can hear down the hall. So
Right.
that's wisdom. That's not intelligence.
Right.
I've heard enough
Right.
crouping cough to know, or,
To know.
the ventilator alarm in room 2 is going off. Is someone in there? Is, just knowing that sound. So, wisdom is acquired with life experience.
Yeah. Yeah. So, on this topic, tell me a bit about, this, you're a clinical coordinator, so you're exposed to all these, kind of connecting these, PA students, and by the way, I say this really, really emphatically and meaningfully. I do believe PAs, even to a degree too, nurse practitioners, they definitely are different in different spaces, but similar in some ways. They're our future, especially in primary care. And I say this I actually have said this to some of my patients, like I'm a dinosaur. Like I won't exist, I don't believe, in 15, 20 years. What I mean by that is, or at least there'll be very, very, very few of us, meaning a primary care, a family doctor, an internist, a pediatrician. Now we could get into like AI stuff and why that might be too.
Yeah.
But I see more and more of the PAs, the nurse practitioners, these mid-levels, and they're amazing. I mean, I'm all for them. I mean, I have many that work for me. But tell us about the program and tell us a little bit about your thoughts on that.
So the PA, physician associate, now the name has kind of officially been changed in Michigan, but we use the term at Michigan State PA.
By the way, I wasn't even aware of that. That's interesting.
Yeah,
it's a physician associate now. Interesting. Okay.
Yeah. It's our program uses PA just because it's just easier. I think the public is learning more and more about PAs and having more experience with them. So a name change might not have been the best time, but I see the root of it, that they want to be more of an associate than just your helper assistant. But So Michigan State PA program is now, we have graduated one class. It is a 27-month program. They have 15 months of didactics, so 4 semesters sequentially without a break of didactics. And then they do 12 clinical months of rotations like we did as medical students, exactly the same as a med school rotation, 4 weeks, with the provider rotating through different rotations. But our program is new in that sense. We just have accepted our 4th class already that will start in May of 2025. We have 38 students per class, and that's a hard cap at 38. They do about 50% of their didactic coursework is done with the osteopathic medical students at Michigan State. So they're sitting in class with them, they're learning with them, they're interacting with them, which is nice because once you're out, you're going to have that interprofessional interaction. And so that starts early in our program. They also have experts in their field lecturing to them, which is nice. So, we go, trying to think of the best way to explain it. Our program is extremely competitive, as is PA medicine in general. We had this past year about 1,600 kids apply to our program.
1,600.
1,600.
Wow. Okay.
And we take 38.
How many? You take 38. Wow.
The average grade point for a student getting in our program is around 3.9.
Wow.
So that's not to say some are a little lower and quite a few are a little higher, but it's crazy competitive for them to get in.
Wow.
And you know what, sometimes you get kids like that and they can't interact. Like we talked about emergency medicine, you got 2 minutes to interact. These kids are social, they're fun, they're nice, they're sharp, they're quick. Enjoy that. It's heavily dominated by female, as medicine is becoming.
Yeah, I find that very interesting.
We have about
that's in the physician world too, isn't it? Isn't that in the physician kind of world too?
I think both med schools at Michigan State, MD and DO, both are about 50% female right now. But we have about 5 guys out of 38 in each class that are guys. So it's just the way of the profession, and that's a national trend. That's not just with us.
Yeah.
But it's competitive to get into, and they work hard, and they should. I always tell them, if they get accepted, I go, you should be proud of what you did and where you are. And typically kids that get accepted to our program are accepted at multiple different programs because they're the kind of the top of the heap. And I always tell them, you got to do what's best for you. We would love to have you, but you did the work to get here. Now you get to make a choice. But I have enjoyed working with them. It's really, they have my cell phone. They call me. It's almost I feel like the parent role at sometimes, advising and telling and working with them. And even when our first class graduated, all of a sudden I became I was helping them hook up with jobs and stuff because I'm out networking with the different systems and I know who's looking. So it's been a great fit for me.
Yeah. Yeah. That's wonderful. No, that's good. That's great. And the networking of that, helping the youth or helping a young professional like that, how rewarding, and that's awesome. Love it.
Right.
What is there other surprises, if you look at the last, say, 20 years or so of where this kind of, I know it's different than ER, but this educational base is, or is there changes that you see a bit? Cause I mean, you had residents coming and interns and stuff, in and out of the, the hospital you're at. So any things you see different or, trends?
Yeah. in general in the world, things are different, right? When we worked, people didn't care if you worked a 36-hour shift. You were back the next day, and I think the world's a little kinder, gentler. Probably, we're old and think they should do it because we did it, and it's probably not the best model for learning or patient care either. So that's different. I'd hate to use the word soft. They're softer than we were. Recently, as yesterday, I told our clinical group of kids, they were talking about they've been grinding a little bit in their clinical rotations, and I told them to suck it up. I go,
Yeah.
come on, you're only in your fourth rotation, suck it up. So
Right.
then I had to kind of back off that and be a little nicer, but
Yeah.
I deal with them a little bit. Humor is kind of my outlet and my communication style, and I think they know that and accept that from me. But it's a different world, but they're doing the work and they're learning the things. I think medicine's way more complicated now than when we went to school. I mean, this just the different medications. Take diabetes, for instance. We used to give
Oh,
people
geez.
insulin and tell them to watch, their diet. And now it's a
Yeah.
subspecialty of a subspecialty. And,
Right.
I
Yeah.
could no more manage someone. I could manage a DKA patient, but I don't think I could manage an outpatient diabetic.
Right. Yeah.
Um,
Yeah.
you know,
Well,
so
I do, and it's definitely different than it
hard.
was even 15, 20 years ago.
Sure. Yeah. So, they have a lot more that they're responsible for. But as you said, that the PAs, the APPs, APP is a term, advanced practice provider. We use that to encompass both physician assistant or associate, physician associate, and nurse practitioners. Um, about 85% of APPs at this point in time are employed by hospital systems, whereas
80%. Wow. Yeah.
85, yeah, and according to statistics in Michigan, 70% of 70% of physicians are employed to
Hmm.
physicians, as opposed to
Wow.
being like you, private
Yeah.
practice.
Yeah.
So, um, but more and more, the shortage of physicians in primary care specialties, family practice, pediatrics, general surgery, ER, those kind of things. That's where these providers are going to help us out a little bit. They
Yeah.
can
For
come in,
sure.
they can help support, take care of things. Often that allows the doctor to have more time to see a patient who may need more critical care or a higher level of attention.
Yeah.
But I call them kids. I always want to say kids because they are kids to me, but they're sharp. They're good. It's not saying they can't take care of those patients, but they're going to fill that void
Yeah.
where, in 2 years we can put out a PA and it takes 8 years to put out a doc.
Right. Yeah.
So
Yeah. And I think too, which we'll see what happens, in the future of medicine, but it is, well, you said it, where the world, by the way, is a little softer. My kids, I'll just say
correct.
my kids, they're a little softer,
Sure.
and,
Yep.
but in that, it's not a bad thing or like that in that way. It's just
Right.
different. And the thing
Right.
about it, I think is that you know, this how should I say this, the programs or the PA programs, there's practitioner programs, these programs fit into a place where, it is clinical. It's didactic in the sense of like, that's why they work for me so well, because in a clinical practice, they have a great lifestyle and,
Hmm.
they are rewarded for that. Like you said, they're very intelligent and bright. So it's not about that. And you didn't have to find somebody that went through, an 8-year program, might be bitter, needs to make tons of money to achieve and pay off all these
To pay
medical school
off.
debts. No, seriously,
Correct. Right.
and I say it bitter, not because, but that's what you hear about, it's like not,
Hmm.
you hear about like, oh, I got all this debt and I need to make this money. And I hired a doctor in my practice a couple years ago, and some of the interviews from all over the country I had that I was fortunate enough to have a lot of, interest. I mean, it was just basically about how much they could make because they had so much debt. And some of these people were in their
Yeah.
40s and 50s. And I was
Correct.
like, man, wow.
How
So
long's your
it's
career window at that point?
right.
How long are you going to
Exactly.
work?
Well,
So,
exactly. I mean, some of them, it seemed like they were still in, that earlier stage, but again, I mean, that goes
hmm.
also back to this primary care specialty, in my opinion, by the way, in the insurance model in that world, traditionally, it's it's not really feasible, really. I don't think
Hmm.
anymore. I think there's got to be some adjustment there. We'll see, obviously, whether politically, economically, Medicare, whatever, kind of
All
what
right.
happens in the future. But it's that's too where I find that the PA, nurse practitioner is a great fit in primary care. They have in the experience I've had is they're very vested in the patient, which I love.
Hmm.
They really care. I mean, they really care, and they're bright, and I might sound a little bad, but I think a little less ego, which is good. I think, you know.
Hmm.
So
Well, these like we talked about, 1,600 kids. All these kids could have gone to med school if they wanted to, if they
yeah,
had the ego, if they had the need for that, you know, title.
right,
They could have done that. They chose to go to PA school because that's what they wanted for whatever
yeah,
reason that is. Whether they want to start a family sooner, whether they want to get on with their life, whether they like the buzzword we use is lateral mobility, because your family practice PA could leave you and go do endocrinology. They could go do general surgery. They could go do women's health. You're a family doc, ER doc. You're you're educated where you are. Right.
yes,
If I love surgery, I can't just say, "Oh, I want to be a surgeon now."
right,
I would have to do residency. Uh,
right,
you know, so these kids are trained as generalists. They go through things. If you're a doc or a practice looking to hire someone, you hire a PA fresh out of school. They're sharp. They've got the base core learning, and I think their didactics probably equals what looking back at my med school. I went to med school in Chicago. We had 4 semesters of didactics. We had a summer off, which nobody does anymore. But so we just had 4 semesters. We went into clinics. Well, they have 4 semesters of didactics. They're taking it with the docs, the medical students, and then they do 1 year of clinical rotations instead of two, and then go into practice. Well, if you're a primary care doc and you hire a fresh PA, they don't have burnout. They don't
right,
have bad attitudes. They they don't have bad habits. You can teach
right.
them what you want. And if you keep that person, like my wife always said, she was in a residency teaching program. She goes, the surgery residents come in and by year 5, they're awesome and they can take care of business, but you got to work to get them there and then they leave.
Right. Right. And
She
then you
goes,
start over with the
yeah, I
next
think if
one.
I had hired a PA 20 years ago, they would know my every whim and thought and my
Right.
practice styles and there's a big benefit that way if you can get someone and keep them. You
Yeah.
know.
No, no, absolutely. And that's like in our practice, why it's worked so well is I'm really big about reproducibility and how I created like our 6 point model. It was basically what I noticed in a fellowship I did, that was in like a regenerative medicine through University of South
Hmm.
Florida. But it was that, okay, and then I needed help because I had a fairly big practice. It grew pretty quickly, and and then what happened was I was like, hey, when I got my first PA, and I was at the time, and I literally just laid down some foundational things that were reproducible, and things that patients would get good care and not missed. And like you said, you kind of like like your wife experiences still,
Hmm.
you kind of cultivate that. I truly appreciate them, value them. So, meaning they're rewarded in many ways, not just money, but
Hmm.
also time and autonomy and all that stuff.
Job satisfaction. Yeah.
Oh yeah, yeah. I mean, they don't. I have people with me 15 years, and obviously some younger ones that I brought in the last several years. But my point is that they like it's worked great because you follow this model. They have autonomy. They can look at genetics and hormones and diets and fix somebody's lifestyle stuff because we allow time in the visit for that stuff. And then obviously we can also come together. The other practitioners and myself, we can come together on
Hmm.
difficult cases, and it's worked really, really well. In fact, I have a book coming out about my 6 point model because I really believe it's the core of primary care. It's like if you really use these things, you're really doing good prevention and good care, and there's great satisfaction. So, but the PA and the nurse practitioners too. I don't want to discount them because I both
Correct.
is
No,
that
and my background is with PAs, not MPs, so I hope no one's offended by that. But we have some great MPs who are preceptors for us in teaching,
yeah,
and a couple of our best preceptors are MPs, but
Yeah, yeah, absolutely.
for an educational model, a different situation, and they don't have the lateral mobility as much as a PA, but
True.
and their educational model is different, but they're great providers.
Yeah, yeah, yeah. And it's becoming more and more the norm. I'll never forget this. My dad, in the I want to say mid 80s. It could have been late, but I think it was the mid 80s. He had a PA and no one knew what a PA was.
Yeah,
I did. I mean, it was like, and
right.
he
We
had a
didn't have
PA.
what. Yeah,
What's that?
I said when we applied to med school
Oh, yeah.
100 years ago, I didn't
Yeah.
even know that was an option, and it
Right.
existed.
Yeah.
But Western Michigan's had a program for over 50 years. So,
Right. You're right. Exactly. So, it was there, but he,
mhm,
and then when we kind of saw how that worked, and it's just, at first it was very averse. Patients were very averse to it. Now it's very normal. It's like,
mhm,
it's actually, it's actually, I think there was a threat at first in primary care, and now I think it's like well accepted, or at least getting
right,
there. You know what I mean? So
right.
I definitely embrace it. You know,
Some of that
I,
goes back to the ego, like you said. You know, like I don't know if people feel threatened or what it is, but I don't think the goal of the PA is to replace the doctor in any means. I think the goal is for them to work together in team-based care and patient-centered team-based medicine.
yeah,
And that's what they're taught, and that's should be how they're entering the profession, and
yeah, yeah, yeah.
it's good. Good
So
deal.
I want to dig a little bit into this just because, before we leave, this is great because I wasn't aware of this till you shared this with me not long ago. But you and your wife have done really big, meaningful mission work. And
Mhm.
and I think that's obviously such a blessing and so kind of you. The biggest thing is I always say the biggest commodity, most important commodity in the world, and that we all have is time, and you give them your time. Obviously, your expertise and professionalism and all that. But tell us about that.
Well, I'll tell you first, mission work or going places going and mission work could be done 2 miles down the road, right? So
Right.
don't get me
Right.
wrong, and we do some things locally with people in need, and Michigan State has a big street medicine program where the students, both medical and PA, will go out in the community and work with homeless people. And so, but our mission work is primarily based through initiated through our church. My wife is a general surgeon. She went into surgery because she had a heart for mission work. um, and as a missionary physician, doing surgical work is awesome. You can go on a medical mission and treat someone's blood pressure for a week, and then you leave, and what's going to
Who
happen? Their
knows? Right.
diabetes, what's going to happen? But if you go there and they have a breast cancer, or if they have we do a lot of hernias, a lot of hydroceles, a lot of OB. We have OB go with us. They do hysterectomies. These women are bleeding. Pre-op hemoglobin's 5, and you
Wow.
don't really have blood bank. You don't have blood to give them unless someone who has O blood who wants to donate, which we do. Um, these people would die, so it's nice to go in as a surgical team, fix some problems. The places we go to do have local physicians there that do follow up care, so they're not just lost to follow up. So it's tied in and it's controlled that way. But it's been a great experience. And it's not like you're zooming in there with your cape on to save everyone. I always tell people, if you come with us, you'll learn that you're going to get more out of this than you're going to do for anyone,
Yeah.
because you're going to come back with a whole new insight on what's real. And
Hmm.
when you take your 12-year-old kids into northern Haiti to do a mission, and
Yeah.
they're sweeping floors and carrying crap around and playing with the local kids, and
Yeah.
just seeing that, my son in ninth grade, the biggest concern he was is that for basketball they needed black shoes for away games and they needed white shoes for home games, at $120 a pop back then.
Right. Right.
And I'm
Right.
like, that is not a real that's not a real problem, okay?
Right.
So, and he had been to Haiti. He's been 2 or 3 times with us, and you just come out of there with a whole new set of understanding of what it means and how blessed we are to live where we do and do what we do, and to be able to go and, like you said, give of our time, give of our expertise just to help these people.
Yeah. Yeah. Yeah.
And that's not to say Haiti is not as an American, you go in there, it's not the greatest place for me. I wouldn't want to live there. but the
Right.
people that are there are amazing. They have
Yeah.
very little. They're joyful, they're happy, they're respectful, which as an ER doc is nice, you know. They're
Right.
so grateful for everything you do, even though it could be minimal.
Right.
Um, it's everybody should do it at least once.
Yeah. Yeah. I've done some mission work and actually
Hmm.
done inner city, actually
Yeah,
through Beaumont years ago. This was back when
right.
I was, a resident in my first few years of medicine. But it's very moving. It is definitely an eye opener. The sad part is
Hmm.
it's something that one thing that you said though, and I didn't really think about, when there's a surgery and you can make an actionable surgery change, and
Fix it.
obviously they have follow up, it's done. I mean, it should be done.
Right.
It's
It's the
like,
beauty of surgery in general.
mm,
We all
yeah,
in medicine we treat things and try to make them better.
right,
Living with a surgeon, she fixes stuff. I
right,
mean, you have a bad gallbladder, they take it out. It's better.
right,
You
right,
don't give
right,
them
yeah,
drugs for this or that, or,
yeah,
and she's a DO, so she's trained lifestyle and modification, mind, body, soul, the whole thing. So, and she takes that to heart. But it is a special skill set, and that's why she did it. So I
yeah,
have that
yeah,
to go
yeah,
to these places. So,
yeah, yeah. I love that. By the way, share this with her because I've read this before and I firmly believe it because when I have patients that I know are having surgery, and most of them, I won't say all, but say 80% are elective in most, like a
right.
knee or a
Hmm.
cosmetic or, so we're not talking necessarily life and death. Yet I've had a few,
Cancer, whatever.
yeah, some cancers, correct. And I've had a few, actually just one come to mind, that had to have a bowel resection because of really, really bad diverticulosis and
Hmm.
litis. Long story short is the mind body. You said something that just made, and I've read studies on this and I can attest to this. We work on that stuff with patients going into their surgery
Hmm.
and the prep, the pre-surgical stuff
Hmm.
makes a
Prehab. Yeah.
huge difference in outcome. I think for them mentally and though the physical healing and that, but there's studies on this and I know she knows that, but just tell her I brought that up.
Well, as in your practice, diet, exercise, maintaining your weight, protein
Oh,
intake before a surgery, your diet.
oh, yeah.
If you're, protein short, if you don't have enough
Right.
protein, you're not going to heal well.
Yeah.
So she preaches that big, you need to be consuming protein. You need to be having, your diet needs to be high in protein to get you through the healing phase. But so much of medicine now for a knee replacement is prehab, you know, you need to go get strong before surgery so
Right.
you can recover quicker after. So
Yeah.
that side of your practice, I think, is fascinating, and I love what you do. And I wish you were local. I might have to drive down there. I don't have a primary care doctor. I tried my best. I'm a
Yeah.
doc. I'm getting old. I need a doc.
Most docs don't
But I
have
just
docs. I find out because I have
I'm
a few
trying
that
not to
see me
be
now.
that guy.
Yeah.
I'm
Yeah. Well,
trying not to, but I've
yeah.
gone to see a few, and I just not. I don't. I can do mostly what they're doing. I can get lab.
Exactly
I can,
for sure. Yeah.
but
Yeah.
you offer a little bit more outside the box for that, which is
Yeah.
super interesting for me. And
Yeah.
we may have to talk offline about that.
Yeah, yeah, oh, yeah, yeah.
But
Well, I just what
yeah.
I found was for me because again being a physician and one of the reasons I left my father's practice, which he was a great, well-respected primary care doctor,
Hmm. I
and it
know him
wasn't
from forever ago in
yeah,
the
so it
ER.
wasn't anything about he
Colin.
did or anything. It was just more of like our philosophies, and I was really athletic and into exercise and stuff like that. And
Hmm.
I was to me, I couldn't. It was like I love. It's so funny because I love the ER where I could do a procedure and I could even get bloody and I could fix something, kind of like your wife. And at
Yeah.
least for that
Right.
time, it'd be done. Like you made such a change,
Hmm.
maybe, and obviously it's it's an ego boost, whatever. But you feel great. You help somebody,
Sure.
that kind of thing. And then I went into primary care because of the family, you know, model. I missed my kids, my wife, and life was just,
Sure.
it was just, whatever I call it. I call it, I was a little tormented by the missing, some of their things. And so when I made that change, what I didn't realize is there's a lot of non-compliance and there's a lot of just like, treat and street and like, oh, and some people want that, which I guess God bless them if that's what you're looking for.
Hmm.
That's not my kind of patient. I want a patient that's wants to get better, that wants to lose weight, that wants to move their body, that, is interested in, living longer and even not longer,
Better.
healthier, better, you know what I mean? And so so that's where I think I guess call it got lucky, but it was innate to me because it was like, hey, if I'm working out and I'm eating right and I'm, looking into these things that as I age, which really started when I was like mid 30s, 38 ish, where I started noticing stuff. Nothing major, but you start noticing stuff,
Sure.
And I was like, wait a second, my patients need this. And then once I started doing it, it just was like a no brainer because, and what's funny is that attracts those people. And by the way,
Right.
many are overweight, many are on meds. We're not talking, I
Mhm.
have some Adonises that are all bodybuilders or some,
Yeah.
what I mean?
Yeah.
Because people sometimes think like, you're like, no, I see but these are people that, hey, they're sick of the broken medical model of the treat and street and the drug patching and all that. And I write the drug, obviously, but we're going to try to work on lifestyle stuff that's really going to make a difference. And then sometimes I got big in genetics. I love the new technology and stuff with genetics and just
Sure.
looking at what's going to be our biggest preventative thing for you personally than just like, well, this is what we kind of, the U.S. Preventive, Disease Task Force has said like we should be doing, you know what I mean? Which is not
Mhm.
bad. But, which by the way, I read a study on that this morning that was very bothersome. We'll have to maybe talk about this off the air, but how they might go to the Supreme Court, how they're trying to discount the U.S. Preventive Task Force and say that they are not elected or they're not appointed appropriately. So their recommendations are not
Hmm.
acceptable. Have you heard this? It's in Texas.
No.
And
You
it's
mean
going to,
like recommendations for cancer screening versus or
you
what?
absolutely like a colonoscopy or even HIV
Correct.
testing for
Yeah.
like, and so
Right.
those things won't be covered. And so there's this big debate like, well, if these people were appointed and they're making the recommendations and they're not quote unquote qualified. And again, it's in the courts right now, but in Texas, they're talking about it's gonna go up to the probably the Supreme Court. So sorry, I digressed in that, but it makes me go, you got to be kidding me.
Interesting.
We're gonna start like putting the brakes on more prevention's a problem, you know.
No, and I've always thought, it's cheaper to keep people healthy than to treat them when they're ill,
For
right?
for sure.
So, right. So if you're intervening, if you're a good family physician where you know your people and you can talk to them openly and tell them those things, In the ER, I get my little 10-minute window of time to tell them, like you got, I can take care of you when you come in here, but if you don't care when you leave, you
Yeah.
keep coming back with the same thing. You got to
Yeah.
care. I can't care for you. So
Yeah.
you got to put in the effort and do the work and follow up. But, again, like you said, inner city mission work, I feel like I did that for 25 years, seeing uninsured patients who
Yeah.
had no other resources. So I
Right.
feel like I did do my US mission work also, but, but I love the model of what you're doing and I wish there were more people doing it and closer to me. That'd be nice.
We'll talk
but,
about that. Maybe
but
Mel, but a separate
yeah.
clinic.
Yeah, right, right. Well, I know a couple people up here doing a ER doc guy I know, and actually another ER doc female who's starting a practice,
Yeah.
going into similar. I need to
Yeah.
sit
Yeah.
and talk with her about what she's doing, but
Yeah. Yeah. What I
so
find, and that's why I'm writing this book is it should be out about 4 or 5 months is that, not that, by the way, my model, you hear this deep six thing, and I say it right
mm,
there openly. It is not rocket science. Yes, there is some deep science you have to know medically when you get in my practice and you're in front of me, but
mm,
it's really just, you know, there's people getting into this field, which I love, but like, oh, I just do hormones, so, oh, I got a med spa. So we just, we're going
weight
to give you,
loss.
we do weight
Yeah,
loss and we're just going to give you
yeah,
peptides and,
yeah.
or we're just going to do the, well, okay. And I'm not going to knock it all because some of it's good intention, et cetera. But my point is you can be missed and missed many things. And you're under the assumption that no, I got all this covered. Well, you don't. And that's when bad things happen. And also sometimes in this kind of space, bad, it looks bad. It's like, oh, you went to some doctor, you got juiced up on all these hormones inappropriately, super
Hmm.
physiologically, all these side effects.
Hmm.
And then hormone, quote unquote, whether we're talking women or men, is all bad. And that's not, accurate. So that's why I love kind of this approach and sharing this approach to like, no, we got to look at all these things and consider these things to give you the best care.
Well, and I think you are a good example for your patients. They come see you, you're in good health. you're active, you're working out, you're doing things. I remember as a medical student in the 80s doing rounds with the oncologist, and down the hallway in the hospital outside each room there's an ashtray on the wall, right? And the
Oh,
oncologist has got a cigar he's smoking between rooms, and he puts in the ashtray as he walks in, reeks of cigar smoke,
yeah,
to his oncology patient to preach
yeah,
to them about. And then, all the
yeah,
nurses are smoking at the desk.
yeah.
You go to see your family doc and he's, 300 pounds and telling you got to lose 5 pounds. And
Right.
so, I
Had
think
one of
it's
those
a good,
recently, by the way. Had literally.
did you?
I mean, they
Yeah.
said they said they love their doctor. Don't get me wrong. They're like, oh, but he's talking to me about some things I need to do, and I'm just not buying it because when I'm looking at him, and I felt kind of bad because I'm
Correct.
like, yeah, I'm sure he's a great doctor. I'm not,
Right.
but it's kind of probably hard to receive.
Well, you got to walk the walk and,
Yeah,
talk the talk. And I think if you're a good role model example for your patients,
yeah,
but, it's not easy stuff to say, hard to
yeah,
do.
for sure, absolutely. Now I'm going to finish, and this is in the honor of your wife's birthday today. Okay.
Okay. Yes.
So
Yes.
we're going to talk a little funny story and finish up here because a funny story about medicine that I'll share because you just said something made me think of one of my dad's stories. So my dad took a practice over in Detroit from a guy and this is in the late 70s. And he was great primary care doctor. Everybody loved him. Very busy. I mean, the lobby just full. Okay, on 6 Mile in Detroit. And my dad started working for him. He smoked. This was normal, by the way, in a medical
Hmm.
practice. He
Sure.
smoked cigarettes all day long. And
Hmm.
at noon, his nurse, Alice, and I know this because my dad's told this story so many times. This nurse, Alice, she was supposed to scotch on the rocks right at
Yeah.
his desk
Yeah.
at noon.
Yeah.
And so, and every
Get
day,
him
that
through
was,
the afternoon. Right.
and what's crazy, that was normal.
Right.
It was
No,
normal to smoke and to drink and see patients all day long.
the nursing station when I was in med school, just overflowing ashtrays, and nurses all sitting there just, writing in the chart and,
Yeah.
just smoking away everybody.
Yeah.
Now,
Can you imagine?
no,
Yeah. I mean,
I
you can't even
can't.
imagine. I can't even, I mean, if you
No.
saw even an image of that, you'd be like, whoa, whoa.
Just talk to your kids about getting on an airplane with a smoking section, or a restaurant with
Right.
they're
Yeah.
like, what are you talking about?
Yeah,
how,
exactly.
how
Yeah.
does that work? So,
Yeah. Yeah. That's so things have changed for the better.
right, right. Well, hopefully
Yeah.
keeps moving that way. So,
Right, right. Well, hey, Dr. Richardson, Dan, appreciate it immensely. Fun talk, good stuff. A lot of,
mhm.
obviously you're living the right way. I appreciate that. And I'm sure your students do as you mentoring them and that. So keep it up. And I'm happy to touch base with you about, primary care stuff later.
Yeah. Well, and I just, in closing, want to tell you, if anybody out there, I don't know who your audience is, who's going to see this, but if anyone has questions or interest in our program, it's Michigan State University College of Osteopathic Medicine, PA Medicine. So big, long title. Just Google MSU PA Med, and our website's there. It's all on explained down there. I'm listed on there as faculty. My cell phone is the phone number there. My email. I'm happy to talk to anybody if they're thinking about PA medicine, if they want to know what to do to get in,
Yeah.
or if there's providers. I assume you have a lot. Would love to talk to anybody about hosting a student, mentoring a student, having them rotate in the office. We're always looking. There are 10 PA programs in Michigan, and it's very competitive. We're all going after the same docs for the same things.
Yeah.
And there's a
Yeah.
lot of learners out there, but especially pediatricians, women's health. I'd love to talk to them, but MSUPA, Google it. We pop up. I'm happy to talk to any of them.
Love it. Love it. Yeah. And I'll send some things your way. Some other
Yeah.
docs help you out.
Yeah. That's awesome.
Yeah.
Love it.
Yeah. Yeah. Good stuff. So thank you again. And again, out
Okay.
there, thank you again for joining me on the Deep Six podcast. Hope you've enjoyed this, deep dive into a little bit of ER medicine and, the change into education where medicine's headed here with our PAs in the future. Thanks again, Dr. Richardson. Appreciate it. And we'll see you again here on the Deep Six.